everyone. My name is Mohammed Ranavaya, and I'm the Senior Associate Dean for the Continuous Medical Education for Marshall Health Network and Marshall University School of Medicine. It is our pleasure to present this CME On Demand series, uh, which is today uh, lectured by Professor Robert Walker. We are honored to have Dr. Walker, who is going to give a presentation, which is going to be a series on geriatric lessons. So lesson number one would be dealing with declining memory. Dr. Walker has a Master of Science as well as a Doctorate of Medicine. He's currently board certified by American Board of Family Medicine with the certification in geriatrics, as well as American Board of Preventive Medicine in the field of occupational medicine. He currently serves as the Chief Division of Geriatrics. Dr. Walker has been a physician over 50 years and currently still is practicing the specialty of geriatrics. I could go on and read his illustrious bio, which will leave him 5 minutes for his presentation. Therefore, I would just go ahead and do some housekeeping announcement, which include the CME credit for this activity. This activity has been approved by Marshall University School of Medicine for 1 hour of the AMA Category 1. And Marshall University School of Medicine is accredited by the Accreditation Council on Continuous Medical Education, ACCME, for granting CME credit. The disclosure of conflict of interest is available on request and is part of this presentation. Faculty and planners of this activity, including myself, did not disclose any relevant financial relationship for this CME activity. Since no relevant and eligible companies were involved in planning, controlling, or delivering our CME activities, no RFR mitigation was needed. Marshall University, by its policy, requires instructors, planners, managers, and other individuals who are in position to control the content of this activity to disclose any real or apparent conflict of interest that they may have is related to the content of this activity. All identified real or apparent conflict of interest are thoroughly reviewed and resolved by the Marshall University School of Medicine's planning process for fair, balanced, scientific objectivity in terms of both the studies mentioned in the material or used as a bias of content, scientific objectivity of patient care recommendation. Disclosure information, if any, will also be presented verbally or in print to participant. With that, I would like to invite you to attend Dr. Walker's lecture, and I welcome Dr. Walker to present the topic of dealing with declining memory. Bob?
Hi, it's a real pleasure for me to be able to talk to providers across West Virginia and Appalachia about a subject that's close to my heart. I mean, one reason is I'm an older adult myself, as you can see, and then people are aging, and the fastest growing part of our population are the 85 and older. So I'm going to try to give some practical advice and to also tell you how we handle a lot of these issues at the Center for Healthy Aging at Marshall University, which has its main office in Barboursville, West Virginia. And first up on the slide, your slides will be our lesson goal and learning objectives. We really have one goal, that the learner will develop a confident and competent initial approach to concerns about declining memory. And then I have the other more detailed objectives that you should be able to if I do this right, you should be able to fulfill those at the end of this lecture. Now, this is meant to be the first of many discussions about geriatrics from the Center for Healthy Aging, which is part of the Department of Family and Community Health at Marshall University Joan Edwards School of Medicine. Now, these are mainly meant for primary care physicians, but also for subspecialty physicians who see old people. I mean, almost all of us see old people, and certainly you don't need to be a geriatrician to see older people. In fact, there aren't enough board-certified geriatricians in West Virginia to accomplish that. But so these lessons are intended to be people who see these folks in their office. They're all about encounters with older Americans and their families. And so this first lesson is going to deal with cognitive decline and the dementias. And this very first lesson will focus on normal memory changes with aging, as well as mild neurocognitive disorder, which is a diagnosis. And we'll talk about those things here in a minute. So when you care for older people like I do, and I know you see this, whoever you are out there, you're constantly dealing with families and patients saying, gosh, I'm worried about my memory. I'm losing my memory. My wife's losing her memory. My husband's losing her memory. My grandmother's losing her memory. Or neighbors or spouses. So this could be a complaint that comes from the patient, or it could be a complaint that comes from observers. And so one of the first things I want to deal with, how do we deal with these concerns about memory by observers or patients themselves? I hear it all the time. And of course, we'll talk about why that's important in just a minute. But we hear things like, I walk into the room, can't remember why I was there. I'm losing my car keys all the time. Or a little more seriously, my wife asks me the same question over and over and over. So we really need to be careful not to just discount these concerns, although we may think they're normal, but we may also be concerned that they really mean something else. And the reason people are really concerned about this is that dreaded word dementia. We all know somebody living with dementia. And as I say on the slide here, along with cancer, it's the most feared medical diagnosis in the United States. And there's good reasons for that. 1 in 10 Americans age 65 has dementia. And that risk goes sharply to about a third of those people over 90 have dementia. As we live longer, the risk is going to continue to increase. And it's increasingly likely that we'll know someone, be close to someone who has that disease. So the concern is not unfounded. So first, we're going to spend a little bit of time, since we're talking about decline in memory, on what memory is, or review a little bit the physiologic and anatomic basis of memory. So people, when they worry about memory, are worried about dementia, and these will kind of hook together. So human memory is complex. We know that. And it's a system that we perceive things, we see, hear, touch, and we process that into a way that can be stored in our brain, of course. And then we've got to be able to retrieve that information when we need it. So this is when we see people say, his memory has really declined, or my memory has really declined over the past couple of years. We need to think about, for a minute, what memory is. So we usually describe the initial coded information when we see something as short-term memory or working memory. Now that may just last for seconds, but there are good reasons to be concerned with declining memory, and we're going to spell those out. So here is the limbic system, and I'm really concerned here about the hippocampus and the amygdala. These are structures that are deep underneath the cortex of the temporal lobe, and they process memory. They do other things too, but they also process memory. So as we go, the initial encoding, as we perceive, from short-term to longer-term memory takes place in those two areas, They're right next to each other, the hippocampus and the amygdala. Now, those make up the limbic system, and the limbic system does other things than memory, but that's to be considered much later, different lecture. So the hippocampus converts short-term memory into longer-term memory. And it also serves as the retrieval area for the brain of memories. The amygdala actually attaches memory and emotion to that. In other words, we could remember stuff, but we have to remember why we want to remember it and analyze that memory. So when we access a memory, the brain actually puts it together, not like a recorded message. It puts it together from fragments that are there in the hippocampus, and that for that reason, our recalled memories are never perfectly accurate. So why do we care about this anatomic stuff? Well, it's a question very relevant to this. And the question really is, why do we worry so much about that one system declining memory and fear that it may be the sign of early Alzheimer's disease or other progressive neurological disease? Why are those two areas the first hint that something serious may be going on in our brain? Well, the truth is those two areas are especially fragile aspects of brain function, meaning they are the place where, with autopsy studies, occasional brain biopsy, which is rare, we find that the hippocampus and the amygdala, these areas we're talking about, are the first structures in the brain to show the pathologic changes. And those are abnormal protein accumulation, amyloid, and inside the cell, proteins that are tangled. And we call those the tau protein. And those conditions seem to show up first in those areas. And so it's not, it's understandable that it is those areas and it is memory that give us our first clue or suspicion that something may be more seriously wrong. Well, so how do we handle this real concern about memory decline? Well, one, we just have to acknowledge with the patient family, this is a legitimate concern. Second, we need to know where to go next. There needs to be a plan for evaluation of this rather than just ignoring it or saying, well, let's see you back in a few months. We'll see if it's still going on. We really need to make a plan and set up the additional evaluation that we need to do to define this. Now, we may define it in a way that offers reassurance to the patient or the family. Everything's okay. But we may find that we need to do further testing, and that's where we're going to go next in this lesson. So we also need to make a more long-lasting plan and be concerned about some areas like early intervention, safety issues that we may bring up at this point. And so let's start looking at how we approach the decline in memory. There's really three main categories if we talk about this in a practical clinical sense. And each of these categories has a different degree of significance and prognosis. So first, there are concerns about memory that are really within the bounds of normal and that we can end up reassuring the patient or their family. Second, there's an intermediate category, and that we're going to spend a lot of time on that today, that'll usually better define itself with time or with treatment. Well, first of all, thank goodness, not all decline in recent memory progresses to dementia. And here we're going to use a book published by the American Psychiatric Association called the Diagnostic and Statistical Manual, 5th edition, and we call it the DSM-5. That manual provides most of our standardized definitions related to mental health and cognition. And so we're going to use those definitions throughout this lesson. So first of all, I'm going to say the DSM-5 actually recognizes the condition of normal memory loss with aging. Now, that's not a DSM-5 diagnosis, but it's recognized as a physiologic condition. So how do we distinguish between some memory decline that's probably due to normal aging from conditions that may signify something more serious, like the other two categories we mentioned? Well, there are some clues to that, but we've got to realize that any decline in memory at all may end up progressing to a more significant condition. So we're going to look at this physiologic condition that the DSM-5 recognizes called normal age-relating memory changes. Well, those are gradual declines in processing speed and working or recent memory and the ability to learn new information quickly. Okay, most of us, I certainly do, experience occasional issues with our memory. This may be mild forgetfulness, misplacing things. With me, it's my car keys or my wallet. Taking longer to recall names or words, forgetting why we entered a room, come into a room and say, why did I come here? Those are all consistent with memory changes from normal aging. And then we're going to talk about whether this decline in memory significantly interferes with our normal daily activity. So before we distinguish memory decline from normal aging from some other significant conditions that we'll define, let's review the terminology related to declining memory in the DSM-5. The first important terms are remembering that normal memory loss of aging is not a diagnosis, but is a condition. The first term to define, it's actually two terms, and they're synonymous. Mild neurocognitive disorder, which is a diagnosis, and mild neurocognitive impairment, which is the impairment associated with that diagnosis. We'll use those terms interchangeably, mild neurocognitive disorder and mild neurocognitive impairment. So the diagnosis of mild neurocognitive impairment, or we call that a lot MCI because we use the mild cognitive impairment, requires observation of a decline in memory. Somebody thinks their memory's not good and it's declining. The patient does, their family does, but then that is confirmed as abnormal by an initial testing. And we'll talk about that. But to be mild neurocognitive impairment requires that memory loss, which is real because it's been documented on some testing, which we'll talk about, doesn't significantly affect important daily activities. So before we consider what that initial testing is that we're basing this on, some evidence of some testing that shows that the memory is abnormal, before we talk about that, let's consider how to evaluate whether the impairment significantly affects daily activities. That's a pretty broad statement. Well, the most accepted method is to determine whether the patient can reasonably complete a series of common activities important to independence in older people called the instrumental activities of daily living. And we refer to this almost always as IADLs. Let me remind you that there are ADLs, which are activities daily living. They're very basic. If you've got a problem with one of those, you've got some significant either cognitive or physical impairment. But the IADLs are a little more complex. And they center on whether the patient is very independent in their daily living. So they're not totally standardized. You'll hear people talk about different IADLs, but we most often, and the gold standard is the Lawton scale. Now, these go all the way back to 1969. I've got the reference at the end. And a list of Lawton IADLs is actually provided in the resources at the end. I'm not going to go through all those, but I'm going to tell you these are more than the ADLs, but are basic in terms of using the telephone, being able to do basic laundry, very basic housekeeping, not hard housekeeping, driving or arranging for transportation, even if you can't drive, things like that. And those things are listed. I've got them at the end, and these are called the IADLs. Now, a lot of people give a checklist. Here, you or your spouse who's with you today, or children that are with you today, grandchildren, you get together here and check off that you can do this. I find that doesn't work very well. What I find works much better is just having a discussion with the patient where you mention all of these things. How do you do it driving? Do you drive? Are you still driving? If you can't drive, could you arrange transportation with someone? How do you do talking on the telephone? How do you do? Could you fix a basic meal if you had to? Now, I want to talk about this a little more depth because this is misused sometimes. So I like a discussion that mentions all of these and see what they say. Sometimes the observer or the other person in the room, which is helpful to have, will disagree with the patient. Then you got to kind of work that out. If the patient can reasonably complete these activities, which we have listed at the end, or if they can't complete them because of not their memory or cognition, but because of another physical impairment, the IADLs are considered intact. Now, let me say one more thing. The issue isn't whether the patient could do a meal, prepare a meal if they had to, but could they? So there's a difference there. So returning to satisfying this definition of mild cognitive impairment, if there are observations of decline in memory, so there's a concern, and evidence on a reliable test, but the patient can reasonably complete IADLs, they're considered to have met the diagnosis of mild neurocognitive impairment, meaning, yeah, there's some abnormal memory issues here, but they aren't affecting the patient or their independence very much at all. And we usually put that in the record as there is evidence of mild neurocognitive impairment. So, what's the significance of this? Well, mild neurocognitive impairment, now we are talking about a real diagnosis in DSM-5. And that diagnosis is an intermediate designation. That means it's a diagnosis that kind of in between normal memory decline of aging, which we talked about, and what would separate normal memory decline of aging? The testing. There is no abnormal testing. We're going to get to that testing, but the testing's normal, and the testing relates you to people your age and so on. So this is a diagnosis in between normal memory decline of aging and major cognitive disorder, MSD. Now that's a very serious designation because the DSM-5 does not use the term dementia anymore. They use the term major cognitive disorder. Very serious, very disturbing to the patient and their family, and frankly requires more confirmation than we've listed so far. So let's now talk about some of this testing we're talking about. And I'm not going to review all the testing, and there are good reviews of that. This is a practical discussion, so I'm going to tell you about the one we use as our initial kind of screening. We often don't use that term, but it's appropriate. The initial test we use at the Center of Healthy Aging is the Mini-Cog. I know a lot of you know the Mini-Cog and have used it. Why do we use it? It's fast. It takes about 3 or 4 minutes to do. It's accurate and simple. It's been pretty well validated, and I'll give you some of those percentages. And the other thing is it can be administered by staff at all levels. It doesn't require a physician. It doesn't require an RN. It does require a little bit of online, at least, training and some oversight at first by people's supervisors, but that makes it very practical. Now, let me tell you right now, if you get on the Mini-Cog website, they will offer training, scoring. They'll even let you print out papers that you can keep as the permanent record. So that's a very useful website. The Mini-Cog, a lot of you are used to it, but I'm going to go through it. It combines recall of 3 unrelated words with a little bit of distraction. So 3 words, have the patient repeat them back. I'm not going to go through the whole thing because it's well covered on that Mini-Cog site. But 3 words, patient says them back so you know they heard them. And then we give a version of the clock drawing test. Now, the details of this are readily available online. They're better than I can do, and I'm going to send you there. But the test in the end is scored by the number of words recalled of the three and a simple defined pass-fail standard for the clock drawing, which includes correct placement of hands. So I may say, can you, and I usually give them the circle already drawn so they don't have to draw the circle. Fill in the clock. You know, this is interesting because young people now don't look at clocks. They have digital things on their phone and computer. But anyway, clock, we may have to change that in the future as we go. But 12, 1, 2, 3, all the way around to 11. And then I tell them, can you put a quarter to 11 or 11:15, longhand and shorthand? Again, some young people may have difficulty with that. And see if it's reasonably clear and all that. But how you score that is really better done online. So in this lesson, we're going to recommend the Mini-Cog for rapid cognitive screening and screening for really the diagnosis, mild cognitive impairment, and separating it from the designation, which is really not a diagnosis, of normal memory loss with aging. In the primary care setting, the Mini-Cog demonstrated, as we say here, 73% sensitivity, 84% specificity across an N of 5,620 patients. And that makes it acceptably effective or reliable. Not perfect, just takes 3 minutes, but it's pretty good. So if the Mini-Cog shows evidence of a neurocognitive disorder and there are significant deficits in IADLs, now you're talking about a possible diagnosis of major cognitive disorder. Now, we would never make that diagnosis with what I've just described. That's going to require further testing and further evaluation. But really, so does mild cognitive disorder or mild cognitive impairment. Both of these require more evaluation. The major cognitive disorder really has very serious connotations. And at that point, you really need to be a good communicator and know your patients and so on. But we'll return to that later. And we're going to have future lessons that deal with that. We're just doing normal decline in memory with normal aging and MCI or mild neurocognitive disorder today. So let's talk now about some treatable causes of MCI. Everything that's MCI isn't aging beyond normal aging or going on to Alzheimer's. There's a lot of things that can cause MCI, and a lot of those are treatable. So sometimes if they're treatable, we're going to mention these conditions. We don't know till they're treated because you can have a treatable cause, but also have idiopathic or progressive neurological changes. So here we're going to point out the more likely, more serious, and more treatable conditions that can be associated with this. Common one is medication. And really, we ought to really think about this. If people say, you know, it's when he started that medication or when I started that medication that I began doing this, or you actually look back in the record and say, you know, that's about the time we started this medication. Always think of medication early. So you really need to examine the patient's medication list. And then you need to ask them about over-the-counter and herbal things too, because those can all contribute. So there's a long list of those, of course, and any medication is suspicious if it started right about when the decline in memory was noticed. But the most common offenders are the anticholinergic groups, and we know what those. By the way, at the end, I've got a list of the tests we do at the Center for Healthy Aging, and we actually do an inventory of the, and you can get this online, on anticholinergic burden. In other words, you may take 1 strong and 2 weak anticholinergics, including some over the counter, and that will absolutely cause at times mild cognitive disorder. And of course, we know the psychoactive meds, benzodiazepines, alprazolam, diazepam, and so on, can easily do this. And we know that the hypnotics, the Z drugs, the drugs people take purely for sleep. By the way, some of those, like Benadryl, can be strong anticholinergics. So those are medications that are famous for this. And when we're thinking this way, we've also got to think about alcohol and opiates. Surely grandma's not drinking too much or drinking much at all. And I'm sure she isn't taking somebody else's Lortab or something. Let me tell you, it happens. It doesn't happen real commonly, but it happens. Both of those may contribute to decline in memory. And by the way, add on to that cannabis, because we're seeing more and more people use and approved for cannabis for health-related conditions. And too much cannabis, of course, can, like alcohol and opiates, cause minimal cognitive impairment. One that we just been added to this, is sleep apnea. Untreated or undertreated sleep apnea definitely can cause mild cognitive disorder. Well, and then of course we've got things, and usually the context or other symptoms really help us here. Real neurological problems. Head injury, closed head injury. Really common to have closed head injury in the elderly, and they have a period of minimal cognitive impairment or neurocognitive impairment. Usually, we often call that post-concussive syndrome and so on. Usually this clears with time, but not always. Also, closed head injury can contribute to ongoing progressive changes. But anyway, that could be head injury. It could be a stroke a mild stroke that we don't recognize. Could be a tumor, benign or malignant. A lot of things. And that's why we're going to talk about imaging here in a little bit. The other thing is not quite as common. Well, one that is common is Parkinson's. 20 to 30% of people with Parkinson's have mild cognitive impairment, sometimes progressing to dementia. We see a fair amount of Huntington's disease, and it's rare, but not that unusual. And it will have a phase of this. Wilson's disease, we see a little bit, copper metabolism, but those have to run through your mind, especially Parkinson's. And then metabolic conditions. Hypothyroidism, in my experience, doesn't cause MCI very often, but it can. And often you wouldn't know that till you treat it. So if you find it, you treat it. B12 deficiency is the same way. To me, it's rare, but it can do it. And so these are eminently treatable things. So when we talk about how we're going to screen at the next level, we're going to include a lot of these conditions. So if the person has normal memory loss with aging, we're probably going to watch them, not do a lot of additional evaluation, and save that for if they do begin to have an abnormal screening test or show other behavioral signs of problems. But when we make the diagnosis of mild cognitive disorder, we've got to do more evaluation. We can't just stop there and say, let's just watch you for a while. Really, if you haven't already done it, a especially thorough physical exam. I know we always say that, but that's true. And a little higher level neurological exam with some real attention to gait, tremor, rigidity, and speech. Because one of the things we want to know right away is, does this person have Parkinson's disease? Might they have Lewy body dementia, which we'll mention much later. Now, an interesting screen that we're beginning to see more and more in the literature is evaluating taste and smell. Alzheimer's disease, major neurocognitive disorder, is associated with a 90 to 98% prevalence of loss of taste and smell to some degree. So other dementias, Alzheimer's disease, of course, is beyond this talk. We're going to go on. You can have some mild loss of taste and smell with neurocognitive disorder. And that's going to make us follow these patients much more closely, probably, for developing full-fledged major dementia, major cognitive disorder or dementia. And of course, we're going to talk that those often precede Alzheimer's disease, Lewy body dementia, Parkinson's dementia, and others. We're going to talk about those in our next lesson on practical geriatrics. I have mentioned here, you can get testing kits, pretty good testing kits, and they aren't real expensive. And I've got the online. At the end, I've got the address where you can order these. Now, what else do we do? Well, at the Center for Healthy Aging, I can tell you what we do. We get, and of course, you may have had these recently anyway, because you may get this as part of your normal evaluation, but we get a CBC, a complete clinical metabolic profile, CMP, we call it, the different serum B12 and TSH. That's our basis. Now, if they've been recently done, within a year or so, it's very unlikely, other than the TSH, we'll probably repeat that. We don't routinely, like a lot of centers do, draw folate or screen for syphilis or HIV. Now, we will do that screening if the history implies some increased risk, but we don't do it routinely. We do always get an imaging study of the brain. We feel like, and the data is backing this up more, that a patient with a diagnosis beyond normal memory loss of aging, which isn't a real diagnosis, deserves at least one imaging study of the brain, preferably an MRI without contrast. Now, if they've had a head injury or been in the ER and gotten a fairly recent CT of the brain, we'll probably accept that. Now, if it shows some little minor effect, we'll probably go ahead with the MRI. And then some patients just can't have an MRI for different reasons, but usually metal in the body and so on. In that case, we do get a CT scan, not as good as the MRI. And we'll talk about that also in future lessons. So, a diagnosis of mild neurocognitive disorder, the step beyond normal memory loss of aging, requires follow-up care, evaluation, and additional testing. So what we do next, and probably this should be done, especially in those, really in everybody with that diagnosis of mild neurocognitive disorder, is to get a more extensive, at least office-based evaluation of cognition. We're going to tell you what that is in our center. So we schedule the patient. We do this, of course, right in our clinic. We do a follow-up appointment every 3 months, and the next appointment will be for more extensive office-based cognitive evaluation. Now, the more extensive testing is going to confirm and sometimes redefine our initial diagnosis. The regular follow-up is real important too, because we can just see how the patient's doing. Is their communication skill tailing off a little? In other words, getting to know this patient if we don't know him real well already and say, yeah, something's going on here. So remember that mild neurocognitive disorder is a transitional diagnosis that can go in either direction. We'll talk about that in a minute. So with the additional cognitive testing, and I've got all of the testing we do at the Center for Healthy Aging appended to the end here. I've got a list of all the things we do next. Those may lead to a diagnosis of major cognitive disorder, which is now the DSM-5's word for dementia. And we're going to focus on the dementias and the actual diagnosis of dementia and the implications and the follow-up in our next lesson. So we provide that cognitive testing, that extra testing, which I've got the list of those things appended in the back. We do that in our own office, but depending on where you are and what you do, or group practice, whatever, you might choose to refer these patients. And the referral is interesting because in some communities, neurology wants to see these patients. In some communities, psychiatry wants to see these patients. And in some may have available even geropsychiatry, specific psychiatry for older people. and or a geriatric office like ours. You could go, can't go wrong with any of them. A lot of those are set up. We do most of the evaluation in this area around Marshall, but in your community, neurology or psychiatry may do that. So when you do refer these patients, if you do, or no matter what, that patient's still in your primary care. And boy, is that helpful, because you're going to see them back and they're going to say, my memory's worse. Now I'm having this kind of problem. And of course, the referral source doesn't know that patient, doesn't know their history. And so it's real important for you to stay in touch with these patients. And then most of you out there are good communicators. You've learned that, but it does take some communication skills with the patient and family and caregivers to give them reassurance, to give them, in some cases, ameliorate guilt. It's okay to get frustrated with this, to the patient or the caregiver or the family. And at that point, you need to establish a plan for care. I mean, I don't know if it has to be written out formally. I think it's good if it is and it's in a note. And that plan needs to consider things like independence. Or is this person going to be able to stay at home and remain independent with the amount of help and oversight they've got? Safety. We always concern about turning on a burner or wandering away and all that. Now, technically, with mild neurocognitive disorder, they shouldn't do that. But maybe that diagnosis has progressed, and we're going to talk about the natural history of that in just a minute. Driving, almost invariably, unless they're not driving already, comes up as an issue. And we may even do a separate lesson on deciding when, how, and when, and how you can evaluate people for driving. And then we may want to do some further interventions. We may want to suggest this or that, and we'll be talking about some of those as we go on. So I want to talk just a minute about, in studies, what happens to people who have been diagnosed with mild neurocognitive disorder. Well, we've mentioned it's a diagnosis, but it's transitional, and so it's unstable in many cases. So it's situated between the decline in normal aging and actual dementia or major cognitive disorder. Well, the studies show that about 50% or so of patients remain stable when they're next seen, or seen over their next several intervals. 40% transition to major cognitive impairment or dementia, unfortunately. And 9 or 10% actually get better. And that's usually in people that we found treatable causes and treated. But sometimes, we don't know why it gets better, but they've got more support. They were seriously depressed and we didn't recognize it, whatever. But about 10%. It's important, I think, to tell patients this does not always go on to dementia or even always stay where it is. It can improve. Now, again, that's a small percentage that does that. So let's talk about intervention in mild neurocognitive disorder. Is there anything we can do medically, a drug, a treatment, to make these people better or that's associated with improvement? Well, some studies that are reputable, but they're very small, show a modest benefit from exercise, memory training, and socialization. Now, I think we need more work in that to prove that those interventions are really helpful. But there are studies that showing they can be helpful. And of course, some exercise, increased exercise, memory training, and more socialization doesn't hurt anybody. But I want to stop short of saying they're usually helpful and usually can really improve people. No, the data shows pretty modest improvement and no improvement at all in many cases. And some of those are questions, because they're very small samples. Let me just summarize and say no medication or dietary supplement have been shown to result in improvement in mild cognitive impairment. So, we use certain drugs for early Alzheimer's and in dementia, major cognitive disorder, and those are the acetylcholinesterase inhibitors. So you know them, donepezil, galantamine, rivastigmine, and those can cause, especially in some patients, some significant improvement that's usually, unfortunately, pretty short-lived. That's not been shown with mild cognitive impairment. They've shown no improvement, and we usually do not suggest them at that point. Nor, by the way, do they lower the percentage of people that go on to progress. In other words, if I give you these drugs, you might not go on from mild cognitive impairment to dementia or major cognitive impairment. They just haven't been shown to be effective that way. Now, a couple of things have been shown to be effective in the risk of dementia in general, not just with people with MCI. And one of those is control of hypertension, which is interesting. So control of hypertension has been shown to lower, for all of us, the risk of dementia by controlling hypertension well. So that's reasonable to do and get good blood pressure control. Of course, we would want that anyway in patients with mild cognitive impairment. We're not sure it makes any extra difference in mild cognitive impairment. By the way, other things people might think about: antiplatelet medication, often effective for frequent TIAs and things like that. Statins, same way. Improved diabetic control, smoking cessation. Unfortunately, those are all good things to do, but they have not been shown to improve MCI or its progression to dementia. Now, again, they can be real effective with these other preventions, stroke prevention, TIA prevention, and so on. So, but we're not really treating their MCI with those medications. So we're going to kind of stop here because we're getting increasingly close to discussing the dementias, the major neurocognitive disorders. And we're going to do that, but it's going to be in the next lesson because this is a lot to try to take in all at once. So I'm going to summarize the lesson here briefly. Declining memory in older adults is an increasing concern. You're going to be faced with this a lot as more of us live to be older and more of us have a concern about Alzheimer's dementia because we know somebody who's living with dementia. That half of Americans now know somebody living with dementia. So, two, just a little bit about memory. It's processed in the hippocampus and amygdala in the deep temporal lobe. But the important thing about that is it's been shown that the pathologic changes under a microscope slide associated with neurodegeneration happen in those areas first, which explains why decline in memory is such an important prognostic or concern aspect of our medical care, and we get asked about it a lot. It's good concern because it's not a bad thing to be concerned because those areas are more fragile to neurodegenerative disease. You know, this is a little over simplification, but I think it's really helpful. I don't think it's a big oversimplification. There are three major diagnostic categories: normal age-related memory loss, which is not an actual diagnosis, but it's a condition; mild neurocognitive impairment, which is the next step up; and major neurocognitive disorder, which is simply another name anymore for dementia. So the diagnosis of mild neurocognitive impairment, that step up from normal memory loss of aging, requires a decline in memory confirmed as abnormal by some initial test, but which does not significantly affect the important activities of daily living. And I have those listed at the end of this presentation. And then finally, mild neurocognitive disorder is a transitional diagnosis. It's probably going to rarely get better, commonly stay the same, but also fairly commonly progress to major cognitive disorder. So we carry that away, I think we'll have the essence of this. And so let me just say that we want to provide more of these lessons in practical geriatric care. And the next one is going to be on the diagnosis and classification of the various forms of dementia. So that's a lot to hit you with, but I think it's practical. I think you're going to be confronted with this. And it's good to have an organized approach. Your approach may differ a little from ours. Also, at the end of this is the workup we do and the various testing we do at our more advanced cognitive evaluation. It's all stuff any office could do. Some of it takes a little training, which is readily available online and so on. So look at, and I've got some references listed for some of the things I said, and those are I have the authors in parentheses when I have a reference at the end. So it's great talking to you, and I'm looking forward to the next step, learning about cognitive impairment, and we started today with declining memory. Thanks. Thanks for giving us your attention.
Thank you very much, Dr. Walker. This was a great presentation, and especially the overview and review of how to deal with a patient with declining memory. So while I'm grateful, I have some questions I thought I ask on behalf of the audience. So I practice occupational medicine. Many of our participants in this activity are probably not geriatricians. So how do we tap into or leverage expertise like yours in the region were we to see a case where we are unsure of how to proceed or if we need further guidance? Could you give us some advice on that, please?
Sure. We have a split divisions of geriatrics at Marshall, and both of them have very good people, we think. One is in the Department of Internal Medicine, and one is in the Department of Family Practice, where I am. And at the Byrd Center, for those of you who know it, in Huntington, we have a cognitive disorder clinic. Referrals can be made there. The next step in testing can be made there. We have, away from the main campus, our Center for Healthy Aging in Barboursville. Now, West Virginia University, Charleston, in various forms, also have geriatric referral. We'll take geriatric referral. And all of that, the referral for concern of this doesn't go to geriatrics. It could go, there may be a neurologist in your area that likes to see, wants to see cognitive issues and declining memory. There may be a psychiatrist or geropsychiatrist. So it depends on your area, unfortunately. I think most of you kind of know who wants to see that and who doesn't. I can tell you we're happy to see it in referral, and in my case, Barboursville, the Huntington area. And I'm sure there are providers, subspecialty providers in your area that would be happy to do this also. One thing I didn't mention, let me say that, we do not always get or readily get formal neuropsychological testing, which is long. It can be difficult for patients. It's very valuable, but we usually do a more clinical focused exam and evaluation. And so we don't get formal neuropsychological testing, which probably is also available. And some doctors, when they refer cognitive and memory issues, like to get neuropsychological testing. I'm not against that. We don't do it as our next step.
Thank you. As I mentioned in your introduction, 5 decades of your life, you have practiced primary care, family medicine, and of course, in the last several decades, you also have become a specialist, nationally recognized geriatrician. So as a primary care physician, lacking your credentials and your experience, when do you think is a time, or what are the milestones that a primary care physician should note and say, now is the time for me to consult with someone with a higher knowledge, skills, abilities, experience in geriatric medicine? What are some of the milestones where you think are beyond the the primary care doctor's office, and when should they consult with someone like you?
Yeah, I think that a lot of doctors don't have and aren't really interested in building the capacity for a little more advanced cognitive testing. Now, some do and are really interested in it, and I think that's fine. Uh, Anybody who does Medicare wellness is usually proficient and well aware of the Mini-Cog exam. Now, that's interesting because we're told by the U.S. Preventive Services Task Force, don't screen for dementia. But then we're also told a Mini-Cog or something of the equivalent is necessary and required for Medicare wellness, which I think is interesting. But I think it depends on your own interest because I will say there's some real trouble signs. One is very early or earlier memory decline, uh, patients in their 40s, 50s, maybe even early 60s. I think that may need referred quicker. Uh, Rarely, dementia and cognitive impairment starts without a memory loss. There is such a thing. And some of that is behavioral and can be hard to sort out. I just can't do some things I used to do, and I don't think it's my memory. And I just can't do these tasks and so on. A lot of fender benders in the car may signify that behavior that just doesn't seem consistent. That kind of thing probably needs to be referred pretty quickly. Otherwise, this has often been going on for a while. And so to do the testing, either do something in your own office or see them back maybe in 2 or 3 months may solidify whether you want to refer the patient out. And remember, when you refer it out, as I've said before, you're still their doctor. You're still their primary doctor. So it varies, but I think people, just know what capacity they want to build. Some people build more orthopedic capacity. Some build more mental health capacity. Some like to do more geriatrics or cognitive testing. Depends on what your office is able to do and is likes to do and does well.
Thank you, Dr. Walker. I appreciate your time, your efforts, as well as your offer to do more lessons in this, and we look forward to hearing from you. This program now ends in terms of its time of the allotted for this program. Those of you who participated, I thank you for participating in this Marshall University School of Medicine CME On Demand Enduring CME Activity. This program has been reviewed and approved for AMA PRE Category 1 credit. In accordance with the ACCME accreditation standards to receive CME credit, please complete the evaluation thoroughly. Your feedback is essential for assessing the effectiveness of this activity and for improving future educational program. Physicians should only claim credit commensurate with the extent of their participation in this activity. This content has been developed in compliance with the ACCME's standards for integrity and independence in accredited continuing education, ensuring it is free from commercial bias. To complete your evaluation and claim your CME credit, you can scan the QR code that will be available to you in the next slide with your phone or click on the link below to assess the evaluation form. Once you finish your evaluation, you will receive a certificate of training. We appreciate your commitment to lifelong learning and your dedication to improving patient care.